Hello, and welcome to another minute with Dr. Abiola Ajayi, the MD CEO of ROA Specialist Hospital. It's a lovely day in Nigeria today. I'm going to be stepping away from doing live programs every week because, as you've seen, I've not been able to keep up with it because we've been extremely busy. We've had a lot of deliveries, a lot of cases. I'm going to be doing the pre-recorded videos. We'll still take your questions. We'll still take your comments. Please follow us on ROA Specialist Hospital on all our socials, Facebook, Instagram, X, and TikTok for now. Our YouTube channel is upcoming, and we've got a lot of exciting things coming down the social media pipeline. We'll talk about today infertility, and more specifically, female infertility. One of my favorite topics. This is something that we've seen here a lot of advancement in the last 18 to 24 months because of a lot of research that's been done that we're incorporated into the way we treat women and treat men. Next week, we'll talk about men's infertility, and we'll still have a couple of talks for the next 4 weeks about infertility in general. When we're talking about infertility, in Nigeria, I see a cultural issue where most of the time people point at the woman, and that's why we're starting the women, because they usually bear the brunt of infertility. But most research shows that, especially in cases of primary infertility or secondary infertility, meaning primary meaning you've never been pregnant before, or you've never gotten someone pregnant before, and secondary infertility meaning you've gotten someone pregnant or you've been pregnant before, but you're now having trouble getting pregnant. Both of them have about 50-50 distribution. So 40% of the time, it's the woman that has an issue that needs to be corrected. Another 40% of the time, it may be the man that has an issue that needs to be corrected. And that leaves 20% of the time, or 1 in 5 cases, that both people have something that needs to be corrected. So even though we're talking about women today, I, as of 2024, will not take an infertility case if I cannot address both partners. And if both partners are not willing to engage in the test and the discussion, then I personally will not take them, because your chances for success decrease. And we're all about success here at ROA. So talking about women, we said 40% of the time is something called a female factor. And females have a lot of moving parts, so to speak, that can involve us in infertility. We're going to try and include some diagrams and some graphs in this video. If it's not in this video, we'll add them afterwards. One of the things I will show you is female anatomy. And female anatomy is relatively simple. You have a vagina that leads to a cervix. I call the cervix the window to the uterus, or the window to the womb, same thing. Within the womb is where babies are meant to grow. But outside of the womb, you have ovaries. So you have 2 ovaries and 2 tubes that now enter into the uterus or the womb. And your ovaries generate eggs. A woman is born with all the eggs she's ever going to have at birth, meaning as you go through cycles, as you go month by month, you're losing eggs until you finally enter menopause. Once a month, an egg is supposed to develop in either ovary or in both, which is called ovulation. The egg is developing and now moves into the uterus. That's the process of ovulation. When you see blood, also every month, that's the process of menstruation, where the lining of the uterus sheds and now comes out as blood. Just because you see menstruation doesn't mean you're ovulating. And I have a lot of women that think they're ovulating because they feel breast tenderness, or they see different changes in their mucus. Those could be signs of ovulation, but we're a lot more scientific than that. When you join us at ROA as a woman for infertility, we're going to give you a roadmap and a schedule. And that schedule is important because the second graph, or the second diagram I will show you, is from day 1 to day 28. Most women have a 28-day cycle. And if you don't worry, we know what to do for you. But for the majority of women, it's a 28-day cycle. And throughout that cycle, your hormones change. Women have so many hormones that play a factor: estrogen, progesterone, prolactin, FSH, or follicle stimulating hormone, LH, luteinizing hormone, and still others that play a factor. And those hormone levels change as the days go by in the month. So you're going to get a very specific roadmap. We give you, on day 3, you need to do this blood test. On day 21, you need to do this blood test. On day 2, you need to take this drug. On day 7, you need to do this x-ray test. All of these things are done at a specific time, so that when we get a result, I can easily calculate exactly where it should be. Walking into a lab and saying you want to do a hormone profile on a random day is really not that useful, because if we don't know exactly what day of the cycle you're in, it's hard to know if that value is going to be normal or not. So during your consultation here, we'll give you, and you'll take it with you, a calendar for the next month of all the different visits that you'll need to maintain and the different samples or tests that you'll need to run. Most of the tests are blood tests or scan tests, which are usually not too difficult. We do also do an x-ray test called an HSG, also known as a hysterosalpingogram, long name for a test that's going to check and make sure your tubes, your fallopian tubes, are open so that the eggs actually are getting to where they get to. Besides the hormonal tests, we also will give you some test kits so that you can test whether or not your hormones are high enough at home for ovulation. And what I normally do is I have women either send me pictures of the strips, we have a group for that, or bring the strips into your next visit, and I can accurately predict when your ovulation time is and when you should meet with your husband. It's not easy, it's not accurate to just subtract some days from the last day of your period, which is what people typically did, and typically got around day 14. I've had many instances where a patient has a 28-day cycle and their ovulation day is day 12. And if they wait until that egg stays around for about 24 hours. practically. So if you're waiting to day 14 and your ovulation day is day 12, you may never get pregnant, or it may be difficult for you to get pregnant. So besides some of these home test kits that you take home and the interactions we have as a doctor-patient, we also may bring you in to do some scans where we track your eggs and see if they're growing to the appropriate size during your ovulation period. If they're not, we have ways of increasing their size. And if they're not rupturing and making their way down, we have ways of even triggering that. All of these fall under the umbrella of assisted fertility. So in ROA, we do everything from the initial diagnosis to all the tests, and then we may have to do some assisted fertility. And if you even need to get all the way into IVF, which is in vitro fertilization, we start and end that process here as well. I know I talked quickly. I may have used some terms that are confusing, but I just want to get it out there that one, there's hope. Two, things need to be done at a specific time by specific people, so seek expertise. And three, your husband, because we're talking about women infertility here, your husband or your partner is extremely important to join you in the process. The final note that I'll make is that the most important date that you're going to bring to the appointment is the date of when your last period started, or the date of your last menses. Anytime we ask that question, is the day that it started, and the day that you see blood, whether it's a drop, spotting, or rush of blood, that's day one. That's the most important day to keep track. There are many apps available that can keep track of these dates, or you can keep it in a diary. So the day the period started and how many days between that period and the previous period. If I have that information as well as your other history, we have a great place to start. I'll be glad to answer questions in person, in office, or we also do telemedicine consultations, or you can reach out to us on our socials. You can see our website at www.theroahospital.com. Our numbers on the website as well. I'm Dr. Abiola Ajayi. All our socials are ROA Specialist Hospital, Facebook, Instagram, X, and TikTok, and it has been an absolute pleasure talking with you today. See you later.